But welcome to 2024.
And welcome to 2024 to you too. We've got some great things lined up for our guests for the year, but we're looking to go back and maybe revisit one of the classics.
Absolutely. Our most popular podcast from 2023 was Steve Reed talking about equine neurology and especially EPM, which is always a topical thing which all horse owners should be aware of. And for veterinarians, something that we can never concentrate on too much.
Yep, and Steve is a pioneer in the industry, and there's nobody that knows more about it than him. So we had a great visit with him, so it would be a good time to let people do that again.
Absolutely, and speaking about pioneers in the industry, coming up after Steve Reed the next week, we're going to have Sandy Hatfield, storied manager of stallions in the equine industry.
Yes, Sandy is fabulous, and I'm really excited to have her on the show.
Absolutely. Unique character, blazed a trail, and her insights into management of stallions is just going to be of interest to everybody.
Yep, I agree. That'll be a lot of fun.
Okay, well, let's roll on with the rewind of Dr. Steve Reed talking about EPM. Steve, welcome back to StallSide.
Thanks, Peter. I was exciting to be here.
Yeah, we're glad to have you.
I appreciate that.
Yeah. So what we thought we would do for the listeners today is actually have a bit of a deeper dive into EPM, because that's something that you are very closely associated with. So tell us a little bit about EPM. Take us back to the beginning when people started looking at this condition and what they thought was going on and what subsequently we've found out to be the case.
Yeah, for me, it starts all the way back in veterinary college, because the person who taught me parasitology and protozoology was J.P. Dubey. And if there's anybody who has more publications on parasitic diseases, I'd like to find him. He must have 2,000 or more. At any rate, but Dr. Dubey, early on with protozoal myelitis, everybody was concerned, is it toxoplasma? That's what a lot of people wanted to think that it was. And then, because of the way it divides, he recognized that it couldn't be toxo. It had to be something else. And what everybody jumped on then was Sarcocystis falcatula or falcatula. It's pronounced a lot of different ways. Well, the intermediate host for that is a bird, and what we've learned now is, that it's not Sarcocystis falcatula, and the organism that we finally came around to through the work of Dave Granstrom and one of his grad students who had been a former resident of ours at Ohio State was Clara Fenger. And so what we've learned is that the causative organism, predominant causative organism, we'll talk a little bit about the secondary organism in a minute, was Sarcocystis neurona. And the definitive host for that organism is the opossum. And the intermediate hosts are quite interesting and diverse. So everything from armadillos to skunks, raccoons, even domestic cats. At first, there was some work on laboratory cats, but then they recognized that it was in domestic cats. And I don't know if it's all right to go on a sideline, but during the time that I was at Ohio State and doing a lot of research on this, one of the projects that we did was we had a veterinarian named John Stanek as his master's. He went to farms and bled feral cats. You want to have a resident or student come back angry with you? Ask him to go bleed a lot of feral cats.
Sounds like a good day out, Doc.
Yeah, it does. That's a wild one.
Sign us up, Steve. Sign us up.
Sign you up, yeah.
So can you go through the pathophysiology of how this all happens for us?
Yeah.
Just take us through it.
Sure. So the organism is passed in the stool of the possum, and there's a lot of interesting things about that, including the fact that we don't know. I mean, you'd think, how in the devil's a horse going to get that? Well, one of the things that we did experimentally was we took some of the organism and fed it to the intermediate hosts. In this case, we chose raccoons. And then I don't know whether it's good or bad to talk about it, but the raccoons had to be sacrificed. And then they were fed to the possums. And interestingly, the organism in the raccoon was often found predominantly in tongue muscle and in diaphragm. So what that said to me, that possums are scavengers. They eat anything and every part of an animal that they come upon. And then after the organism is in the possum and undergoes several reproductive stages, both asexual and sexual stages in its life cycle, we harvested it out of the gut. And there were times in 1 gram of possum feces, we could find up to 1 billion sporocysts. So, and a tiny little bit of possum feces in some grain or something, a horse wouldn't even notice it, or certainly not on hay or out in pasture. So, it doesn't take very much, for the horse to probably get exposed. In states that have possums, more than 50% of the horses will show antibodies in their bloodstream, meaning they've been exposed. And everybody's certainly keenly aware of antibodies right now in light of COVID because, the question is, did you get your antibodies from natural infection or did you get them from vaccination? Well, with EPM, many, many horses get exposed to that particular organism and they make antibodies. Very few of the horses that get exposed actually develop neurologic signs. So some of the key things that we might address later in this podcast are what's unique about those horses. Is it something about the immune system of the horse that is compromised? Is it something about the virulence of the organism? Because there are a lot of various, species of the S. neurona. So in other words, there are various antigens that are a little bit different on each organism. So is it the virulence of the organism, or is it simply the number of organisms that the horse ingested?
So I do have some questions. So if you got that many spores in there, is it always a fecal oral contamination there? Are they always eating it? Because sometimes you get these big piles of, especially raccoon feces, and are they ever aerosolized, breathed in, or is it always...
As far as I know, it would be fecal oral route. Yeah. But you're asking a question that I've certainly never investigated, so I don't know, and I doubt that the organism would be there. One of the things that we learned in Dr. Bill Savile's PhD which was all on the epidemiology of this, was that we suspect possums may defecate near where they drink. Because farms that had 2 water sources, so they had a creek or a pond for the wildlife and the horses could drink out of that, but they had separate water source for the livestock, had a lower incidence of EPM. So if the horses, so we just, we don't know, but we sort of asked a few wildlife biologists and they said, possums live on forest edges. They like to come into your barn and eat your dog food, cat food, whatever they can scavenge. And they will also eat, not necessarily the intermediate hosts if they find them dead. But then we also noted that if you had 2 water sources, you had a lower incidence, even though of the disease.
Well, that kind of answers my second question, whether these horses are getting infected in the barns or in the pastures.
Well, they could get infected anywhere, and a lot of people, wonder, could it be in their hay? And so some people even use those hay gain, sterilizers, trying to say we're only going to feed hay that's already been steamed so that it's not going to be able to maintain the organisms. But I would say most of the time they're probably, you'd like to think they're getting, infected in pasture. But then you got to wonder about the show horses and the race horses. They come up with this disease that aren't out on pasture hardly at all. So they probably can get infected any number of places.
Any link between, because you said not all of them show clinical signs. What's the common thread with these horses that get infected? Is it dose dependent, or is it immunocompromised horses?
Well, we think the immunocompromised plays a big role in this. When we were trying to develop a vaccine, one of the things that we did in trying to do that is we went to an area up in Canada that were PMU farms, and they had no possums there, and so we purchased a lot of the young horses off of those areas, And then before we wanted to infect them with the organism, they would get shipped from Canada into Fort Dodge, Iowa. And so one of the things that we know is that a horse on a van for more than 6 hours has a suppressed immune system. And so these horses were on a van for 18 hours. And the way we did it was I examined the horse in Canada, and then I left town, and the local veterinarian would then vaccinate them either with a placebo or what we thought was going to be a protective vaccine. And then I met them when they arrived in Iowa. So I was there to do the exam as they walked off the truck. And so, and then at the end of that, which we thought was a pretty good stress for them, so they're in a new environment and they've just had an 18-hour van ride, we infected them. And we had 24 horses in each group, and every time we did it, at least 20 of the horses developed clinical signs. So we learned a lot from that. Number one, we learned the role of transportation stress, and number two, we learned the vaccine wasn't very effective.
Vaccine didn't work.
Yeah.
So once the organism's ingested by the horse and it sets up, what goes on in the central nervous system? What's the manifestation of infection?
Yeah, that's a really good question, Peter, because, we think that, it's going to be coming in through the GI tract. It's going to then be, at times, get into the bloodstream. And then where's it going to go? How's it going to hide out in the horse? It's probably inside lymphocytes. That's what we'd guess. Maybe macrophages. So it's in circulation. But even still, how does it get out of there into the nervous system? And, what causes that? And that's still a little bit of some of the question that we don't know the answer to, but that is in fact what happens. So the organism is ingested, and it looks like protective immunity is pretty darn effective, because if more than 50% of the horses have antibodies, meaning they've been infected, and less than 1% of the horses ever develop neurologic signs, most times the horse's immune system keeps it in check. So the ones where it does get into the central nervous system are most likely it's traveling in there because they're maybe it was because they had an excessive number of organisms, or more likely it was because we think they were immune compromised for some reason. Now, once it's in there, it can hide out for some time, we don't know how long, inside neurons. Might be in macrophages, but that's not going to survive very long. But in neurons, and it might be sitting there, and perhaps at some point in time, it'll start undergoing asexual reproduction, and so it'll kind of come out of its quiescent state, and then clinical signs might develop.
Okay, what do you see in that spinal cord? If you were to look at it microscopically, what are the classic signs?
Yeah, that's when you see it, number one, it's often gross lesions. So sometimes you can actually, the pathologist will be able to feel areas where the cord's a little bit soft or mushy, and then when they cut through those sections, it'll be discolored. But then histologically, there are going to be a lot of macrophages in there, and they're going to be organisms are rare to find. It used to be, Dr. Tom Divers and us were talking about this a number of years ago. Before we had all of the medications, and before any horse that takes a bad step now, veterinarians routinely put them on EPM meds. And so we rarely find an organism in the nervous system. We'll find lesions, but rarely do you find the organism. And we think that is because so many horses that develop any neurologic sign get treated immediately. Prior to when all these treatments were available, we used to find organism routinely in the histologic slides, so we'd find it. But macrophages and, other degenerate cells are mostly what you're going to find in there, degenerate neurons even.
Do you find them all throughout the spinal cord?
No, it's a multifocal disease.
Okay, and so where do they usually hang out?
Well, that's a good question. They can hang out anywhere. It's rare to have them in the brain. I don't know although my name is on a paper in which we said seizure was seen in 3 horses. So it was published in a pretty average journal, but so maybe even in the brain. But brainstem seems to be a highly selective phase. So maybe the organism, enters somehow from the oral cavity and goes quickly to the brainstem. Interestingly, the horses that develop brainstem signs are often rapidly progressive, and they're often quite responsive to treatment. I know Dr. Morrissey and I have had some with dysphagia and really some cases that we both have managed that had dramatic signs. We don't always win the whole battle, but if you treat them, they often will improve. And one I'm thinking of that you and I both handled improved for a while, then relapsed, improved, and finally went to heaven.
Do you own that horse? Did you own
Did
that
not
horse?
own that horse. Oh,
Steve owns a few of these wiggly horses.
Yeah.
So you mentioned about dysphagia and a few other things. Like classically, people think EPM, my horse appears lame or it appears weak in the limbs. And you mentioned dysphagia. What other things do people present you with, saying, hey, could my horse have EPM? What are the sort of manifestations?
Yeah, most of them are going to be ataxic. So most of them, it's in the spinal cord. But the ones where it's in the brainstem, one of the big things that we worry about are, what about upper airway problems? What about the occasional laryngeal hemiplegia or the dorsal displacement of soft palates? Could those things be caused by EPM? And I know Dr. Embertson and Dr. Woody, they ask me that question often. And sometimes when they've got the odd horse they don't quite understand what's going on with that upper airway, they'll get put on treatment for EPM. But the majority of the time, the horses show gait deficits that involve, since it's multifocal, it's usually 1 or maybe 2 limbs, and it might be on opposite sides of the body. And because the organism might sometimes get in the lower motor neurons, so it might get in those nerve roots, muscle atrophy is a big feature. Asymmetric neurologic signs with muscle wasting that's very focal is the classic EPM horse.
And how do you differentiate that from your classic wobbler then?
So the classic wobbler would be symmetric ataxia rather than the asymmetric, and it would be predominantly all upper motor neuron signs. So you wouldn't see muscle atrophy, in a wobbler. Now, I'm sure if there was enough pinching at a local spot along the side of the neck, we get the odd wobbler that will have a little bit of focal muscle wasting. But most of the time, they're symmetrically ataxic with no muscle atrophy.
Mm. So that's sort of clinical signs. What can you do diagnostically to try to get the answer? I mean, I think everybody who's ever dealt with this condition sometimes has struggled diagnostically because there's no absolutes. How do you approach these cases and try to get the answer?
I think the number one is the neuro exam, because if they're asymmetrically ataxic and they have muscle wasting, you can sort of move EPM to the top of the list. That's probably, there may be a few other things that can be on there, but EPM is going to be near the top. And then you can look at antibodies in the bloodstream, so you at least know they've been exposed. But more critically, antibodies in the bloodstream and in spinal fluid. And we believe that the best diagnostic test is a ratio of antibody in bloodstream to CSF. We all know that the blood-brain or blood-CSF barrier is a pretty effective barrier. So the antibodies in the blood leak into the central nervous system at about 1/100th. So a tiny amount should leak in there. So if you have a high concentration of antibody in the CSF, in the spinal fluid, then that tells us there's a high probability there's organism in there with local production of antibody there. And so when you do an antibody ratio, the higher the concentration in the spinal fluid, that would be your numerator, it will then cause your antibody ratio to go down. So in this situation, a low value is more significant than a really, really high value when you use the ratio. Now, if you're just measuring it in blood or spinal fluid alone, the higher the concentration, the greater the probability the organism's there. So,
okay, so yeah, just to summarize, what you're looking for is there's a natural leakage of antibodies across from the bloodstream to the cerebrospinal fluid, and if that ratio isn't appropriate, that means that antibodies are being produced within the central nervous system. Therefore, there's organisms in there causing disease. Is there anything else that can be done to actually, if you have a borderline test, is there anything else that can be done to try to put them on one side or the other?
Well, we can sometimes we'll look for a specific antibody index on our samples. We've tried really hard to develop a PCR, and there is a PCR test that Dr. Posterla out of the University of California, Davis, has developed, and in their laboratory, it appears to be pretty accurate. Over the last greater than a year, two individuals who see a number of neurologic cases, me being one, and I think everybody in our practice, and the other, a neurologist at the University of Pennsylvania, have requested PCR testing on every one of our blood and CSF samples, and I don't believe we've identified a positive yet. Maybe there's been one, and that's out of several hundred. So we think the PCR test, at least in our hands, has not been very accurate. At the University of Kentucky Diagnostic Lab, they have developed a PCR that has been quite effective used on tissues. So if you find a lesion, either grossly or microscopically, you can go back and do the PCR on the tissues, and it's been quite accurate. Even if the organism's gone, there'll be a signal that it was there. So that's been a helpful thing. I don't know, but Peter, maybe I missed all of your questions. Or something else that
I just wonder if you're going to talk about the albumin quotient.
Well, I sort of mentioned it briefly when I said that specific antibody index, but again, use of things like the antibody quotient or albumin quotient in CSF can be somewhat helpful, although it's pretty rarely used. And then from an experimental point of view, one of the best diagnostic things has been Western blot. But Western blots, you're looking there for a particular size of protein that's coming out on a piece of film or paper that's developed, and it takes a much more an educated individual to be able to select and see that these low molecular weight proteins are present, which are characteristic of the organism.
Yeah, and not too many people run those these days.
That's correct.
Yeah,
that's correct.
So once you've got clinical suspicion in what you've seen, once you've got some supportive diagnostic testing from the things that you've just described, what's your approach to treatment?
Well, there are 3 FDA-approved products, and they were all validated by multi-center trials. The first one that was validated was Rebalance, and that's a combination of pyrimethamine and sulfadiazine. Those 2 medications act by inhibiting folic acid. So they inhibit the folic acid, which has damage to the organism. Interestingly, folic acid inhibition, if used long enough, will also result in some degree of anemia in the actual horse. So you have to be a little bit careful about it. Other toxic side effects have been reported, such as anemia, reduction in white blood cell counts. And one of the worst things that we ever learned was we had a pregnant mare that was so ataxic she had to be held up in a sling. She was only at about 8 months of her gestation, so she had quite a long time to go. We kept her in the hospital at Ohio State, and we put her on pyrimethamine sulfadiazine for several months. When the foal was born, it was born not only anemic, without red and white cells, very low numbers, but part of its skin was missing. So there are a lot of potential toxic side effects for that drug. Now, I don't want to scare anybody away from it. That is a really good product. Most of the time when that's used, people will put the horse on it for 90 days. If you read the experimental trial, it was the horse improved, and all of these had the same sort of gradation. The horse has to be confirmed to have EPM with the best diagnostic tests available at that time. And then they have to improve a minimum of 1 grade over the 30 days of treatment, and they have to maintain 1 grade of improvement for 90 days with no other treatment. That was the basis for the approval of not only the rebalance, but also of the Marquis, which is Panazaril, and the Protozil, which is Diclazaril. So all of those had the same particular clinical trials. All of them have on their label about a 62% effectiveness. It's my opinion that if we repeated those trials, it'd probably be closer to 75%, because my guess is our diagnostic ability is better now. Mm-hmm. So we probably treated some horses that we thought had EPM that maybe didn't really have it. But why would a company, since they've got approval already, why would they want to invest another large amount of money to go back and redo it? So to sort of finish up there, the 3 approved medications, the triazines, Panazaril and Diclazaril, as well as the ones that inhibit folic acid, pyrimethamine sulfadiazine, are the number of products that are most commonly used. Other products that are out there that you'll hear about, Toltrazaril. Toltrazaril is approved in Canada, and it gets utilized in this country. And one pass through the liver, and it becomes the active metabolite Panazaril. So Toltrazaril will be converted into Panazaril, and that's probably why it's effective. Interestingly, when you use Panazaril, you need to do a loading dose. And that loading dose is 15 milligram per kilogram, 1 day only. So what I recommend for people is if they're going to use Marquis, dial out the by weight dose, which is 5 mg per kg, 3 times, and give it to the horse. It's really important for the clients to know how expensive that stuff is. So if it drops out on the ground, pick it up and put it back in the horse's mouth, because you don't want to waste it. With the Diclazaril, the work that's been done out of University of California, Davis, shows they didn't need a loading dose. It was effective right on very first day.
You mentioned how the pyrimethamine sulfadiazine worked, the rebalance. How did the triazines work? The other medications.
Yeah.
How do they work that's differently? Because you mentioned about potential for toxicity with the pyrimethamine sulfadiazine. What's the safety profile on the other? Because if you mentioned pregnant mare, is one better to use than another?
Those are key things. Number one, as with lots of drugs that get approved, it's much easier to not do it on pregnant mares because there's a lot more validation that's required by the FDA. Having said that, the triazines act, what we think they do is they act against an apicoplast, which is something that's actually evolutionarily retained. These drugs, the triazines, are similar to atrazine. It's things that are used on corn and other plant products. And so evolutionarily, it looks like the protozoans retain this little apicoplast, and that appears to be what the triazines disrupt to cause the organism to then die. But as far as safety goes, it's been used, both of those have been used on a lot of pregnant mares, even though there have been no clinical trials done on that, and they appear very safe. The only drug that ever had a trial done on both was nitazoxanide, I believe was the name of that drug, and it's no longer available because it occasionally caused fatal diarrhea in horses. And so the drug, the company just decided it wasn't worth continuing. But they actually did some work on pregnant mares and showed that it was safe in pregnant mares. So just to be fair to all of the products, I wouldn't be afraid to give any one of them to a pregnant mare. I would just be, if I was using the folic acid inhibitors, I would want to only go for 30, maybe 60 days max. I wouldn't want to keep them on there 90 or 120 days because you're more likely to induce some toxicity.
You did mention cost, though, and one of those treatments is a lot cheaper than the others. Is there a difference in efficacy?
Well, as I said, if you read the label on all of them, it says 62 to 65% is the efficacy of those products. And so as far as cost goes, the rebalance, you could probably buy 3 months worth for around $250 a month, so around $750. That would be for 90 days. The diclazaril for 28 days, which is the way it was approved, is about $850, and the Marquis is about $1,000. So there's a significant difference. The advantage of being able to utilize them only for 28 days is certainly something that a lot of people are happy with, and they really, really like that. But if you've got a bad EPM, sometimes we'll give 2 months of Marquis. We don't just go, or 2 months of Protozil.
Yeah, and it's interesting what you're saying about the target organelle. Doesn't look like that occurs in mammals. So that's probably
that's right.
And it's probably a safety profile. And in my hands, I'd say all of those treatments have probably been just as efficacious. And the interesting thing to me is some horses do really well on one. They don't do so well on the other. And sometimes you put two together and you get a better response. Exactly. And so it's not a case of one being better than another. It's just some horses respond better to some drugs than others. So treatment, you've established a treatment course. Prognostically, what are the things you look for in these horses that are affected to make your mind up before and during the treatment period that this horse is going to have an acceptable response and maybe this horse we're going to have to do a bit more work on? What are the things you look for?
I think because protozoans aren't like viruses where the titers, once you start treating them, start dropping rapidly. Protozoal titers, they seem to be more difficult for me to follow and know. And it may be if the horses continue to be turned out, perhaps they're getting exposed on a frequent basis, and that's why their titers don't, go down. So what I base my decision on are the clinical signs. If I've treated the horse and the clinical signs have significantly improved over that 30 days, then I will often stop at the end of that period of time. And what I say to people is when you discontinue the treatment, if the horse has one bad day, ignore it. If they have 2 bad days, you better keep a really close eye on them. And and I say that within the first week after you stop treatment. And if they have 3 days, within the first week after you stop treatment, start the treatment again and then call me. So go ahead and get them back on the medication as soon as possible because relapses are more difficult, seemingly more difficult to treat.
In your experience, what percentage of horses would relapse? And, what would be your expected result if you're going to give somebody the odds? How many do you think will probably relapse within 6 months to 2 years? How many do you expect to have probably a full recovery? How many would you think would not respond?
Yeah, I think that the number that don't respond at all are very minimal. That's a very low number. As I said, if we repeated those trials, I think we'd be up around 70 to 75% success rate in a 28-day treatment. That's what I believe. And that's kind of what I tell people that I'm expecting. The extension of that, as you asked, is there are many horses that will respond to treatment but will have some residual signs. In one study, it's been up to 30% of the horses will have some residual neurologic deficit following treatment. So that's generally what I tell the people. And on the good side, it seems to be, and I don't have a real number for this, but probably less than 5% don't respond at all. And but it's kind of interesting. There are some horses that really get your anxiety level up because they don't make a clinical response until almost day 21. And so you're like, oh man, either I've made a wrong diagnosis or this horse isn't going to respond to treatment. But most horses within 2 weeks are starting to show some clinical improvement. And I'd like to see them improve a minimum of 1 grade. I would say that it's pretty routine now for many veterinarians to treat 2 months. That's become more the norm. And so that means a big expense.
It's a big expense. Some people ask me sometimes about retapping the horse to see if it's negative, and that was something that people talked about early on. What's your take on that now?
It's not something we routinely do. I believe Dr. Fenger did a study in which she treated until the horses went negative in blood and CSF, and it took almost 14 months until they were totally negative. So that's a pretty long time to be treating a horse with any medication. And certainly, unless the pharmaceutical company is giving you the drugs for free, that's going to be a really. So what you routinely do is if the horse hasn't responded or completely responded, maybe at around 3 months, I'll retap them to see whether things are going down. I can tell you that, one of the worst cases and, a total, disappointment for me was a horse that had a head tilt. So it had neurologic signs involving the brainstem. And we did the titers and the antibody ratio, and it gave us a number that was 200. So values that are positive are less than 100. So we felt pretty strongly the horse did not have that. I was suspicious that maybe because it also had a few signs of muscle atrophy around the tail head and loss of sensation. So I was convinced it probably had polyneuritis equi, not EPM. We put the horse on steroids, and it improved. They wanted to breed the horse, so they took it back off of steroids, and within 10 days, the signs came back with a vengeance, and we lost the horse. So even though the antibody ratio is a very good test, and false negatives are low in occurrence, they can occur very less than 3% of the time we've had false negatives. False positives, that's not such a big deal other than it costs your client money because they're going to treat a horse that doesn't have the disease.
Well, you made a good point there when you were sort of saying about the length of time the horses had to be treated out to be negative, and you would expect the majority of the horses to have a favourable clinical response in that time. So really the proof of the pudding's in the eating. If the horse becomes neurologically sound, I mean, that's strong evidence that you've managed the infection. Speaking of the infection, you mentioned another organism. You talked about S. neurona. You also mentioned there's a secondary organism that can cause issues. Would you like to elaborate on that?
Sure. Neospora hughesii is another protozoan that has been seen to cause neurologic disease, EPM, but it seems to be much bigger problem on the West Coast than on the East Coast. Neospora is an organism that's around, and probably the things that we know about it that we worry about are unlike S. neurona, which is totally a fecal-oral transmission. Neospora appears to not only be able to transmit that way, but it can also transmit vertically. So you might be able to pass it down from the dam to the fetus. And so certainly in cattle, they see that in Neospora, and, so it's been reported and confirmed in the horse as well. It looks like the canines are involved as the more definitive host there rather than the possum. But I think we know a lot less about that organism. The people at University of California, Davis, seem to be the ones who've recognized this, most often. Now, they see both S. neurona and Neospora as cause of EPM. We have rare on this side of the country to get a Neospora positive, and we test for it pretty regularly. One of the interesting things about, in California, when you go on the west side of the mountains, so the area going down to the sea, if you will, there appear to be possums there. And so the organism seems to be able to be spread in water into the sea. So other animals that we worry about are marine mammals. Harbor seals, sea otters have all been shown to have protozoal myelitis in some instances. And we think that it's all because of a wash off from into the sea. I don't know.
Talk about prevention.
Yeah, that's something that everybody would like to have because, a number of years back, as I mentioned earlier in this podcast, we tried to develop a vaccine and we just weren't able to get it done. And just to waste 1 minute on that, one of the things that was happening was each time when those horses arrived in Iowa, and I met them as they came off the trailer, I would repeat the neuro exam. And of each group, I threw 2 or 3 horses out every single time. And we did 3 trials. Every time, unbeknownst to me, the horses I threw out had received the vaccine. So there was a concern that perhaps there was some stimulation there that was causing maybe some unusual signs. So that was then everybody just dropped it. So, and it may be now that in the newer day and age of different types of vaccines, perhaps, mRNA or some other new technology will come around and we'll go forward again. Obviously, we got to have a high enough incidence of the disease for anyone to want to put the money into developing a vaccine. So how can we prevent it if we don't have a vaccine? Well, probably the best thing is some sort of subclinical treatment. So let's stop these protozoans whilst they're in the gut, because as we know, in the GI tract, there are going to be a lot of protozoans, not just, the ones that are caused EPM. There may be other bacteria and a lot of stuff that are in there. So the people at University of California, Davis, they did an interesting project on a farm in New Jersey that had a significant number of standard breds that often developed EPM. So it seemed like the environment was right in that area. So they divided the mares in half, and they put half the mares on Protozil and half of them not on Protozil. And then when the foals were born, they maintained the foals on it and ones that were not. And then at the end of some long period of time, let's say a year, and I apologize for not remembering the exact number, they bled all those animals, and the ones that had been on Protozil had no antibody titers. The ones that were not did have titers. So they knew they had a way of preventing it. Now, but you can't put those animals on a product that's that expensive for their entire lives. And who knows whether it's good or bad for an animal to never have seen an organism. Perhaps the first time it sees it, it won't be able to mount an immune response fast enough. So having said that, what a lot of people will do is give a regular dose or occasionally half dose for the first week of every month. People have done that with Marquis. People have done that with Protozil. And when they've done that, it looks like the incidence of disease has gone down. One of the most substantial problems of doing research on EPM is the model. You might have recalled way back at the start of this, I said, but when I was at Ohio State, Dr. Bill Saville, as part of his PhD, we maintained a colony of raccoons. And we maintained a colony of possums. And we Once the raccoons were infected, we sacrificed them and we fed them to the possums. Then we sacrificed the possums and we scraped the lining of their bowel. And that's where I said we sometimes got 1 billion spore cysts in 1 gram of feces. And so that's not a model that anybody wants to do, over and over. And so I wish we had a better way to develop a model, because then I think somebody might be more inclined to go after developing a vaccine. Obviously, if vaccines against protozoal diseases would be easy, malaria wouldn't be such a worldwide problem. I mean, it's a terrible disease, and it's not easy to prevent.
Yeah, I could never understand it, because when the EPM vaccine came out, I mean, was in Pennsylvania, had a client that she wanted to vaccinate. And I can never understand, because there's vaccinations against toxoplasma abortion in sheep, and they're live vaccines made to order. And so I could never understand how you had a similar organism that you were supposed to actually control with an inactivated vaccine.
Yeah.
It just sort of didn't really sort of make so much sense. But all the things you talked about, that's sort of extra label use of the drug. Would that be fair to say?
That's exactly right.
Yeah.
That's exactly right. And all of those things are extra label. And certainly giving it only a week a month is not proper. And then cutting the dose in half again, those are all extra label, ways of doing it. One other thing that he didn't mention that may have a role in all this is, if immune suppression is an important part of this, then agents that might gear up the immune system may also be helpful. And as you know, we'll sometimes try things like levamisole with this idea that can we, support the immune system or gear it up. There are other products that are approved for immune stimulation, and you guys will have to help me. They have slipped out of my mind right now. What are some of the ones that we have in our pharmacy?
There's the Extim.
And Equimune, mycobacterial wall.
Yeah.
Those are the two big
So
ones.
those are things, and so it may be that we need to supplement our treatment with things like that to help the horse as well.
Do you use anti-inflammatories at the same time you're treating horses, steroids? Or
There's a lot of literature out there that early papers that say when you start treatment, you're going to get a big kill, and that's going to make the signs worse. And even though I've said that at meetings, I've never done that. I don't routinely give steroids. I might give non-steroidals like Banamine sometimes, depending on how severe the clinical signs are at the start.
Gotcha.
Yeah. And actually, speaking about some supplementary things, for those of you on the video channel, there will actually be some examples of affected horses, and Steve will be talking about the things that he sees during his examination.
Just click on the link in the description, whether you're on the YouTube channel or on the podcast. So they're there.
Yeah. Steve, this has been fascinating. Thank you for your time.
Thank you.
Thanks, Steve.
Great to be here.
Yeah, I appreciate you being with us. So, just to summarize, though, we need to get rid of the cats in the barn.
No.
Sorry.
That's a really, really good thing. You do not need to get rid of the cats.
Well,
the one thing that you do need to
do a
do.
little controvery. I know everybody out there knows I'm just joking. We're not.
No, but but it is critical to know that if you have a dead cat, bury it, dispose of it, because otherwise those scavenger possums will eat it. And so, but whilst you don't want to get rid of the cats, if you do have one that dies, you want to get rid of that. So that's a really good point you made, Bart.
Okay,
that's a good point.
Good. I didn't mean to, but there it is.
Good recovery, guys. Good recovery. And that was StallSide for this week. See you next time.
Well done, Steve.